Hello, Medicos. Good day to all of you. This is Dr. BK for you, and today I will be discussing about the second part of the orbit, that is the nerves of the orbit. So in the previous class, I have discussed about the boundaries of the bony orbit, the features of the various walls of the bony orbit, then about the fascia of the orbit. Then, more importantly, I have actually discussed about the extraocular muscles of the eyeball and their actions, nerve supply, and the clinical aspects. Followed by that, then we have also seen about the vessels of the orbit, mainly the ophthalmic artery, and followed by that the veins, superior and inferior ophthalmic vein. So as a continuation of the previous class, in this class we will be concentrating on the the nerves of the orbit. So before understanding the nerves of the orbit, first we will be actually learning about the superior orbital fissure. So through this fissure, only the nerves supplying the orbit enter the orbit. So naturally, a knowledge of the superior orbital fissure is necessary to understand the nerves of the orbit, the course of the nerves. Then about the nerves, mainly we will be discussing about the oculomotor, trochlear, and then the abducent nerves. So these nerves mainly supply the muscles, extraocular muscles of the orbit, and not only that, through these nerves, even the parasympathetic component and the sympathetic component also, they travel mainly through the ophthalmic nerve. Okay, so the ophthalmic nerve, its branches and its distribution, which is mainly sensory to the orbit, we are also going to discuss about that. Then finally, we will be discussing about the parasympathetic ganglion, that is the peripheral parasympathetic ganglion of the orbit. Now, here you are able to see this fissure, which is actually called as the superior orbital fissure. The superior orbital fissure, above it is bounded by the lesser wing of sphenoid. Okay, and below it is actually bounded by the greater wing of sphenoid, and medially it will be bounded by the body of the sphenoid. Okay, so now to put it in simple terms, it is actually a fissure between the lesser and the greater wing of the sphenoid. So here you are able to see the lesser wing of sphenoid above and medially, and below and laterally what you are able to see is the greater wing of sphenoid, and more posteriorly only you will come across the body of sphenoid, because this is the medial wall. So medial wall, mainly you come across the frontal process of maxilla, followed by that you have the lacrimal bone, then you have the orbital plate of the ethmoid bone, and more posteriorly only you see the body of sphenoid, and near to the posteriormost end you are able to see the optic foramen. Now, here you will see a ring which is surrounding the superior orbital fissure. Okay, that ring is actually called as the common tendinous ring or the tendon of Zinn. So, due to this attachment, this part of the fissure appears like the retort of a bulb, and medially you have a tubercle for the attachment of this tendinous ring. So now you are able to see that is the musculotendinous ring. Okay, so that musculotendinous ring divides the fissure into lateral part, intermediate part, and then the medial part. So that is the lateral part which you are able to see here, and this is the intermediate part, and then below you have the medial part, that is mainly divided by the musculotendinous ring. Okay, so the musculotendinous ring divides this part of the fissure into a retort or bulb. So nerves mainly enter into the lateral part, intermediate part. So certain nerves are there in the lateral part along with vessels. Intermediate part mainly transmits the nerves alone. Okay. Now this common tendinous ring which we have seen in the previous class itself, it gives attachment to the extraocular muscles, mainly the recti muscles, the four recti from the respective sides. Superior rectus, inferior rectus. Okay, then you have the lateral rectus and the medial rectus. So the subdivisions of the superior orbital fissure is into lateral, medial and intermediate part. So here you are able to see between the lesser wing and the greater wing, it is transmitting so many structures. The nerves which are entering the orbit. Now what are all the nerves which enter the orbit? We will see from the compartment wise. First, above what we saw in the last slide is the lateral compartment. So what are the structures entering through the lateral compartment? Mainly the nerves are lacrimal, frontal and then trochlear. Then the arteries will be mainly the lateral branch of middle meningeal artery and then the recurrent meningeal branch of ophthalmic artery. Okay. So this is the lateral compartment. From above and laterally what you see is the lacrimal, frontal. These two are branches of the ophthalmic division. And then trochlear comes. Okay, you remember it as LFT. LFT. LEFT is left, you remove E, LFT, because lacrimal, frontal and nasociliary is the other branch of the ophthalmic which does not come here. Instead the trochlear nerve comes. Then the vessels, as I told you, the lacrimal branch of middle meningeal and recurrent meningeal branch of ophthalmic artery. Okay. The next, which is actually from the, again it is actually from the lacrimal artery only. Vein, you have the superior ophthalmic vein, which is actually maintaining connection with the facial vein and drains into the cavernous sinus. Superior ophthalmic vein. Next, coming to the intermediate compartment. So in the intermediate compartment, mainly you come across the two divisions of the oculomotor nerve. Okay, the superior and inferior division of the oculomotor nerve you come across in the intermediate part, and between the two divisions you have the nasociliary nerve, which is actually the other branch of the ophthalmic nerve. Okay, nasociliary nerve between the two divisions, and in between the two and laterally what you have is the abducent nerve. So you can see that all the nerves which is related to the orbit are passing through the superior orbital fissure. Lacrimal, frontal and trochlear in the lateral compartment. Intermediate compartment, you have two divisions of the oculomotor nerve. In between them you have the nasociliary nerve. In between and laterally you have the abducent nerve. So this is actually the optic nerve which comes out through the optic foramen along with the ophthalmic artery. Okay. So optic nerve we are not going to discuss in today's class because that comes along with the neuroanatomy in the optic tract. Medial compartment mainly actually transmits the inferior ophthalmic vein. So these are the structures which pass through the superior orbital fissure. So now first let us discuss starting with the oculomotor nerve. The oculomotor nerve is actually purely a motor nerve. It is the third cranial nerve which supplies the extraocular muscles of the eyeball except the superior oblique and the lateral rectus. Lateral rectus is supplied by the abducent nerve and superior oblique is actually supplied by the trochlear nerve. Now, what are the components? Any cranial nerve you actually discuss when we are discussing, you should know the functional components. So functional components mainly refers to the types of fibers these nerves contain. So, apart from the extraocular muscles, it also supplies the sphincter pupillae and the ciliaris muscle through the parasympathetic fibers. So, the components mainly, it consists of general somatic efferent. So, general somatic efferent, somatic means body and efferent is always the motor. So, it is motor to the extraocular muscles. General somatic efferent is actually motor to the extraocular muscles. So here are able to see the oculomotor nerve, which is actually emerging from the midbrain, passing through the superior orbital fissure and then dividing into two divisions, the superior and inferior rami. So first component is general somatic efferent. Then proprioceptive afferent fibers. So this is muscle sensations. This is not the general sensations. Muscle sensations from the extraocular muscles. They travel to some extent via the oculomotor nerve. Then what happens is the lateral wall of the cavernous sinus, they will communicate with the ophthalmic nerve. So ultimately these fibers pass through the ophthalmic nerve and then they are relayed into the mesencephalic nucleus of the trigeminal nerve. That is about the proprioception, which is muscle sensation, whether the muscle is has stretched too much and so like that of sensations. Okay. The general visceral efferent is actually your secretomotor fibers. Okay. Parasympathetic fibers. So that is mainly these fibers, they relay the ciliary ganglion which you see here, and from there through the nerves emerging from the ganglion, they will pierce the eyeball and supply the sphincter pupillae muscle and the ciliaris muscle. So both are responsible for accommodation. So sphincter pupillae is actually constricts your pupil. So and the ciliaris muscle also actually what happens is it adjusts your iris. These two are necessary because when a very flashlight or very powerful beam of light is actually directed towards your eyeball, then to cut off the excess light, your pupil should actually constrict. That is actually called as the constrictor pupillae. So for this, the general visceral efferent fibers. So these three components are present in the oculomotor nerve. Now the oculomotor nerve, any cranial nerve you take, it will maintain connections with the cerebral cortex. They are actually called as the corticobulbar fibers, okay, or corticonuclear fibers. Corticonuclear fibers to all the cranial nerves, they receive from the cerebral cortex, and this is always bilateral. That means from one cortex, it receives to both the cranial nerve nuclei. Okay, it receives fibers from the corticobulbar fibers. Then it has connections with the medial longitudinal fasciculus. So medial longitudinal fasciculus is actually a bundle of nerves which connects the third, fourth and sixth. That is the three nerves which are supplying the extraocular muscles, oculomotor, trochlear and abducent, with the eighth nerve, that is the vestibulocochlear nerve. So there is a communication between these 3, 4, 6 and 8. Why? Because so it helps to maintain your balance. So if you are losing of the balance or whether you are actually maintaining the balance, your eyes also helps to what happens is adjust according to it. So there is always a intercommunication between these two for sensing the balance. Okay. So the origin is from the midbrain and the level of superior colliculus. So the posterior part of your midbrain, this is the posterior part and this is the anterior part. The posterior part shows a swelling. It is called as colliculi. Superior colliculus. Same way at the lower part you have inferior colliculus. So totally 4 swellings you can see at the posterior part of the midbrain. So superior colliculus is actually a visual relay center. Okay. So at the level of superior colliculus, if you take a section, so this is how your midbrain will appear, and this is called as the crus cerebri or cerebral peduncle, and here you will have the substantia nigra, which will secrete the dopamine. Okay, and then the superior colliculus, one more nucleus will be there, which is not shown here, that is the red nucleus. So I don't want to go into those details because all that will be covered in the neuroanatomy session. So now coming back to the oculomotor nerve. The oculomotor nerve nucleus is present in the midbrain at the level of superior colliculus around the central gray matter. Now, if you look at the oculomotor nucleus, you are able to see here, it is actually a nuclear complex. It is actually a nuclear complex because group of nucleus, central nucleus you have, same way you have lateral part divided into dorsal, intermediate and ventral. So they all will be innervating the separate muscle of the eyeball. So I don't want to go into those details. Apart from that, you have accessory nucleus, the Edinger-Westphal nucleus. It is this nucleus which is going to give fibers to the sphincter pupillae and the ciliaris muscle. Now, apart from that, the oculomotor nerve nucleus is also related to pretectal nucleus. So, the pretectal nucleus is mainly responsible for the pupillary light reflex, both the direct and as well as the consensual pupillary light reflex. Direct is actually when you throw a light onto the right eye or any direct eye, what happens is the pupil reacts. Consensual is even the opposite eye, even that is the other eye where the light is not thrown also reacts. That is actually called as the direct and consensual pupillary light reflex. That is mainly by the pretectal nucleus. So pretectal nucleus and Edinger-Westphal nucleus are accessory nucleus of the oculomotor nerve. So the fibers emerges from the medial aspect ventrally. They travel along the substance of the midbrain and emerges medially through a depression here, what you call it as the interpeduncular fossa. So there you are able to see the section, the anterior part. This is what we saw as the crus cerebri. So from the medial part, the nerve is emerging, the oculomotor nerve, from the interpeduncular fossa. Okay, so that is the interpeduncular, because these two are called as cerebral peduncles, and between that is called as the interpeduncular fossa. You have the mammillary bodies and the tuber cinereum, and these dots are the posterior perforated substance. So oculomotor nerve, it has been labeled. This is actually your oculomotor nerve. This is actually a trochlear nerve. Okay. So now coming to the oculomotor nerve course, after emerging from the interpeduncular fossa, what happens is it is seen piercing the roof of the cavernous sinus. So where the tentorium cerebelli, the fixed border and the free border, they cross, at that point what happens is the oculomotor nerve will pierce the roof of the cavernous sinus, and then it travels over the lateral wall of the cavernous sinus. Okay, it travels over the lateral wall of the cavernous sinus. Below it is related to the trochlear nerve and then the ophthalmic division. So these are all the relations on the lateral wall of cavernous sinus, which we have actually discussed extensively in the cavernous sinus class. Then it enters into the superior orbital fissure in the intermediate compartment, and then what happens? It divides into a superior ramus and an inferior ramus. So superior and inferior ramus, which is dividing in the anterior part of the lateral wall of the sinus, and then they are entering the intermediate compartment of the superior orbital fissure. Okay, so once it enters the superior orbital fissure, the superior ramus is actually superolateral to the optic nerve, and mainly it will supply your levator palpebrae superioris and superior rectus muscle. Okay, so it will mainly supply the levator palpebrae superioris and the superior rectus muscle. So this is the superior ramus, which will give a branch to the levator palpebrae superioris and then the superior rectus muscle. Whereas the inferior division of the oculomotor nerve, has three branches, one to the medial rectus, one to the inferior rectus, and the longest branch is to the inferior oblique. So one to the inferior rectus, which you are able to see here, another one is to the medial rectus, inferior rectus, medial rectus, and the longest branch is actually to the inferior oblique. The branch to the inferior oblique will give a communicating branch to the ciliary ganglion. So the parasympathetic fibers to the ciliary ganglion actually travels via the branch to inferior oblique, and from there via the communicating branch which it is giving to the ciliary ganglion. So superior ramus or superior division of oculomotor nerve supplies your levator palpebrae superioris and the superior rectus. The inferior ramus gives three branches, one to the medial rectus, one to the inferior rectus, and other to the superior oblique, which is the largest branch, and also gives a communicating branch to the ciliary ganglion. So that is about the oculomotor nerve. Now coming to the applied aspects, mainly if the oculomotor nerve is actually damaged or injured, you see drooping of eyelid, because the levator palpebrae superioris is not acting, it is not very actively elevating the eyelid, so it is actually drooping of eyelid, one of the conditions, and it will be associated with other conditions. But if you see only drooping of eyelid and other muscles are normal, then it might be due to the sympathetic fibers alone is affected. Okay, Horner syndrome, mainly you come across that. So external strabismus, because the lateral rectus is unopposed, so the eyeball will be deviated laterally due to the unopposed action of the eyeball. So this is actually the external strabismus, because the medial rectus is not functioning. All the adductors, mainly your superior rectus and inferior rectus, are all paralyzed. The eyeball is actually deviated laterally. Then loss of accommodation because of the sphincter pupil muscle. So your eye should accommodate whether to bright light, mainly through the sphincter pupillae muscle, to dim light through the dilator pupillae muscle, which is actually supplied by the sympathetic fibers. So if the oculomotor nerve is damaged, there will be loss of accommodation. And because most of the muscles which is supplied by the oculomotor nerve is paralyzed, the eyeball becomes loose and protrusion of the eyeball takes place, because these muscles exert a traction, which we have already discussed in the last class, how the superior rectus and inferior rectus, they actually produce a traction backwards. They tend to actually pull the eye backwards, whereas the oblique muscle, they exert a forward traction. So these two tractions, what happens is they are counteracting with each other and keep the eyeball in position. Now here, because these muscles are all paralyzed, the eyeball becomes flaccid and there is a protrusion of eyeball. The next cranial nerve which we are going to discuss today is about the trochlear nerve, or the fourth cranial nerve. So it is a very slender nerve, and it supplies only one muscle of the eyeball, that is the superior oblique muscle of the eyeball. Okay, so it only supplies only one muscle, that is the superior oblique, and the component is general somatic efferent component. So general somatic efferent is only to the motor, to one of the muscle, that is the superior oblique. Now this muscle, this nerve also tries to convey the proprioceptive impulses from this by maintaining a connection with the lacrimal nerve. Through the connection with the lacrimal nerve, what happens is the proprioceptive impulses are actually transmitted from the trochlear nerve, these muscle sensations from the superior oblique. So it is the most slender of all the cranial nerves, and it is the only cranial nerve which is emerging from the dorsal aspect. Okay, whereas all the cranial nerves will emerge from the ventral or ventrolateral aspect. Okay, so this is completely emerging from the dorsal aspect of the brain. The nucleus is actually situated in the, again in the midbrain at the inferior colliculus level. So at the level, lower level, inferior colliculus is actually an auditory relay center. Okay, inferior colliculus is a auditory relay center. So the fibers where the trochlear nucleus is present is at the inferior colliculus at the periaqueductal gray matter. The cavity of the midbrain is the aqueduct of Sylvius, okay, or it is actually called as the iter or aqueduct of Sylvius. So around this you have the gray matter or the periphery. So from the periaqueductal gray matter, the trochlear nerve arises. It immediately passes posteriorly and it decussates in the anterior, or you call it a superior medullary velum. So after its decussation from the superior medullary velum, it passes laterally and winds around the cerebral peduncle. So it winds lateral to the cerebral peduncle. Okay, so decussates with the opposite side. Complete decussation will take place, which we have seen in the previous picture. So after its decussation, yeah, here you are able to see complete decussation, and then it actually travels laterally and then anteriorly to, it comes forwards. So that is the trochlear nerve. Okay. So then what happens? It pierces the roof of the cavernous sinus exactly at the same place where the oculomotor nerve pierces it. So at the meeting of the attached at the free margin of the tentorium cerebelli. Then it travels along the lateral wall of the cavernous sinus. So above it is related to the oculomotor nerve. This is the trochlear nerve you are seeing. Below it is related to the ophthalmic division. At the anterior part of the lateral wall, what happens is this nerve crosses laterally the oculomotor nerve. Okay, so it crosses the lateral part of oculomotor nerve because it has to enter into the lateral part of superior orbital fissure. Okay, so it will enter the lateral part along with the lacrimal frontal nerve. So along with the lacrimal and frontal nerve, there you are able to see that is the trochlear nerve, which enters the superior orbital fissure, and then it supplies the superior oblique muscle on its surface. Okay, so here it is present between the roof and above the levator palpebrae superioris. So this muscle is the levator palpebrae superioris. It ascends above this muscle and then passes more medially and then supplies the superior oblique muscle from the orbital surface. The next muscle which we are going to discuss is about the abducent nerve or the sixth cranial nerve. The abducent nerve or the sixth cranial nerve, again it is a motor muscle which supplies mainly your lateral rectal muscle of the eyeball. So the components mainly will be the functional component will be mainly the general somatic efferent, which is going to supply the lateral rectus muscle of the eyeball. So the nucleus is actually situated in the pons, mainly the lower part of the pons, deep to the fourth ventricle. So behind, so here we have seen the midbrain. That swellings are the superior colliculus and the inferior colliculus. Upper part of the midbrain, the oculomotor nuclear complex is situated. Lower part at the inferior colliculus, the trochlear nerve nucleus is situated. So which actually winds back from posterior and then come anterior. This is actually the nucleus which is situated in the lower part of the pons, the abducent nerve. The abducent nerve will wind around the facial nerve nucleus and then come. Okay, that is actually called as the facial colliculus. Okay, so the third, fourth, and sixth nerve all maintain connections with the eighth nerve via the medial longitudinal fasciculus. Now once it emerges from the brain at the lower border of the pons, junction of the lower border of the pons and the upper part of the pyramid, that is the upper part of the medulla oblongata, it immediately passes upwards. And then what happens? It actually passes forwards. So here you are able to see how it is taking a bend upwards and then forwards at the junction of the pons and medulla. Then it passes between the petrosphenoid ligament and the petrous part of temporal bone, where it takes a sharp bend. Okay, and then finally it passes straight forward. So one bend here, and other one. So it actually takes a bends 3 times. Okay, so bends forward across the upper border of the petrous part below the petrosphenoid ligament. Then you can see within the substance of the cavernous sinus. So the nerve will be inferolateral to the internal carotid artery. The nerve will be inferolateral to the internal carotid artery within the substance of the cavernous sinus. Okay, so that is the course of the abducent nerve. So because of its very long intracranial course, this nerve is more prone for stretching and injury. Okay, intracranially. And this one more peculiarity of this nerve is this nerve is more medial, the most medial nerve emerging from the brainstem. More in a median plane it is present. So then I told you it enters within the substance of the cavernous sinus, and then it is inferolateral to the internal carotid artery. Then it enters the intermediate compartment of the superior orbital fissure. So it enters the intermediate compartment of the superior orbital fissure between the 2 divisions of the oculomotor nerve. So within the 2 divisions of the oculomotor nerve, and laterally what happens is it is present. And then what happens? It supplies the lateral rectus muscle. Finally, it supplies the lateral rectus muscle from its orbital surface. So that is about the abducent nerve. So coming to the clinical aspects, mainly trochlear nerve superior oblique muscle is actually paralyzed if the trochlear nerve is damaged. Then what happens is the person, when he actually tries to look down, he will complain of diplopia or double vision. Okay, he will actually complain of diplopia or double vision on looking down. As far as his gaze is straight, there will not be any problem. When you ask him to look downwards, what happens is he won't be able to look downwards, and laterally he might fall down. So that what happens, on looking down, he will try to keep his head forwards on the affected side. Okay, then he will not be able to look unable to look downward and laterally, as I told you. So there is one test which is called as Belskowski phenomenon. When you actually tilt the head to the opposite side, or the affected side, the eyeball, actually the intorsion should takes place. Okay, because superior oblique is again an intorsion. When this intorsion is not happening, then actually what happens is it is a positive Belskowski phenomenon. Next is abducent nerve creates internal strabismus because lateral rectus is paralyzed. So unopposed action of the medial rectus will actually result in the internal strabismus. Okay, because the lateral rectus is paralyzed. That is one thing. The nerve might damaged in intracranial, increased intracranial pressure, or even in stretching of the nerve can be takes place. So next, coming to the ophthalmic nerve. So ophthalmic nerve is actually the smallest division of the trigeminal nerve. The other two are the maxillary and the mandibular. ophthalmic nerve is purely a sensory nerve which arises from the trigeminal ganglion, which is situated in the fossa for the trigeminal ganglion in the middle cranial fossa on the anterior sloping surface of the petrous temporal bone. From the anterior part of the ganglion, you can see the three branches arising: the ophthalmic, maxillary, and the mandibular. Okay, so the ophthalmic nerve actually it is traveling in the lateral wall of the cavernous sinus. It is present below the oculomotor and the trochlear nerve. At the anterior part of the lateral wall of sinus, it divides into lacrimal, frontal, and nasociliary, and then enters the superior orbital fissure. Lacrimal and frontal will enter the lateral compartment of superior orbital fissure, whereas the nasociliary will enter the intermediate compartment. So here you are able to see the lacrimal nerve, then you are able to see the nasociliary and the frontal nerves. So which are all entering via the superior orbital fissure. So lacrimal nerve is actually present along the upper border of the lateral rectus. So along the upper border of the lateral rectus, you can see the lacrimal nerve. Then it will actually run almost laterally on the roof of the orbit, and it will supply the lacrimal gland. Before supplying, it will maintain a communication with the zygomatico-temporal nerve. This is thought to supply post-ganglionic parasympathetic fibers to the lacrimal gland, because the ganglion associated with the parasympathetic part for the lacrimal gland secretion is by the pterygopalatine ganglion. The largest peripheral parasympathetic ganglion provides parasympathetic fibers to the lacrimal gland as well as to the mucous glands of the nose, palate, and the pharynx. Okay. So here you are able to see the lacrimal nerve. So the zygomatico-temporal nerve, as I told you, conveys mainly the postganglionic parasympathetic fibers from the pterygopalatine ganglion to the lacrimal gland. So then finally what happens, it gives sensory branches to the lacrimal gland, as well as it is going to supply the eyelid, lateral part of the upper eyelid and the conjunctiva. The next nerve which we are going to discuss is the frontal nerve. So here you are able to see the frontal nerve again, which enters the superior orbital fissure from the lateral compartment. So it is present on top of the levator palpebrae superioris muscle. It is present on top of the levator palpebrae superioris muscle and below the roof of the orbit. It divides into a supratrochlear and supraorbital nerve. Okay, so it divides into supratrochlear and supraorbital nerve. Supratrochlear nerve actually passes above the trochlea. So it actually travels along the medial wall and then passes above the trochlea. It will give a branch to the infratrochlear nerve, a communicating branch to the infratrochlear nerve. Then it will supply the eyelid and then the conjunctiva. Then finally what happens, it will emerge through the forehead deep to the corrugator supercilii, and then it supplies the medial part of your forehead and scalp. Okay, so supplies the conjunctiva, skin of medial part of upper eyelid and lower part of the forehead. It is present medial to the supraorbital nerve. So supratrochlear nerve is actually a sensory nerve of the scalp also, apart from supplying the eyelid, medial part of the eyelid and the conjunctiva. The next branch of the frontal nerve, okay, is the supraorbital nerve. So here you are able to see the supraorbital nerve. So supraorbital nerve, what happens is it runs again on top of the levator palpebrae superioris and divides into medial and lateral branches. So the supraorbital nerve will actually divide into the medial and lateral branches, and it turns upwards to the supraorbital notch, or sometimes the notch might be converted into supraorbital foramen. So this you would have seen in the norma frontalis. So above the superciliary arch, or the upper margin of the orbit, you can see that. Supraorbital nerve. It mainly supplies the conjunctiva, eyelid, and forehead, lateral part of the forehead, lateral to the supratrochlear nerve, and supplies the scalp as far as the vertex or lambda, up to the lambda. So it's a very long course in the scalp, and it also supplies the mucous membrane of the frontal sinus. Supraorbital nerve also supplies the mucous membrane of the frontal air sinus. So that is about the frontal nerve, which gives rise to mainly the supraorbital and supratrochlear nerve. Next, we are going to discuss about the nasociliary nerve. So the nerve passes forwards and medially above the optic nerve. Actually, it mostly accompanies with the ophthalmic artery and present medial to the ophthalmic artery. So crosses the optic nerve from lateral to medial side along with the ophthalmic artery, and finally continues as the anterior ethmoidal nerve. Okay, so continues as the anterior ethmoidal nerve, which is entering through the anterior ethmoidal foramen. So anterior ethmoidal nerve, in the medial wall of the orbit, there is a foramen. Through the anterior ethmoidal foramen, it will pass through the crista galli and then enters the nasal cavity and divides into medial and lateral nasal branches, which will supply the anterior part of the nasal septum and also the lateral wall of nasal cavity. Okay, so the lateral wall of the nasal cavity, the lateral nasal branch, finally will come out as the external nasal branch and also supply the sides of the nose, external nose. So that is about the anterior ethmoidal nerve, which is supplying the anterior part of your nasal septum and also the anterior part of lateral wall of the nasal cavity. So that is your anterior ethmoidal nerve, which is a branch of the nasociliary nerve. The next branch of the nasociliary nerve we are going to discuss is about the long ciliary nerves. So you are able to see the long ciliary nerves. So the long ciliary nerves, they are usually 2 to 3 in number. They pierce the sclera and they mainly supply the ciliary iris. Okay, cornea, ciliary body and the iris after piercing the sclera. So they are mainly seen traveling above the optic nerve. So they are sensory to the cornea, iris and the ciliary body. They also carry parasympathetic fibers to the dilator pupillae muscle. Apart from the short ciliary nerves, some of the fibers also travel via the long ciliary nerves to the dilator pupillae muscle, which receives sympathetic fibers. So sympathetic fibers will actually come from the plexus surrounding the ophthalmic artery, because sympathetic fibers, they always travel along with the blood vessels. Then it also gives a communicating branch. The nasociliary nerve will give a communicating branch to the ciliary ganglion, through which the what happens is the sympathetic fibers are also conveyed from the internal carotid artery. Then you have a infratrochlear nerve. So supplies the eyelids and then the side of the nose. Supplies both the eyelids, medial part of both the upper eyelids, lower eyelids, then the side of the nose and also the lacrimal sac. Because it passes below the trochlea, it is actually called as the infratrochlear nerve. Then finally you have the posterior ethmoidal nerve, which passes to the posterior ethmoidal foramen and supplies the ethmoidal and sphenoidal air sinus. So the branches of nasociliary nerve are anterior ethmoidal nerve, long ciliary nerve, communicating branch to the ciliary ganglion, and then finally the posterior ethmoidal nerve. So these are the branches of the ophthalmic nerve: lacrimal, frontal and nasociliary. So finally we will just discuss about the ciliary ganglion. So it is a peripheral parasympathetic ganglion situated in the orbit. So where actually it is situated? Near to the apex of the orbit, between the lateral rectus muscle and the optic nerve. Okay, so it is mainly related to the oculomotor nerve. because the fibers are mainly from the oculomotor nerve functionally, but structurally you can see it is related to the nasociliary nerve. So structurally it is related to the nasociliary branch of the ophthalmic nerve, but functionally the fibers are actually derived from the oculomotor nerve. So that is your ciliary ganglion with its branches and the roots. Now it is situated near to the apex of the orbit, as I told you, between the lateral rectus and the optic nerve. What are the connections? It has parasympathetic root, it has sympathetic root, and it has also got sensory fibers. Now remember, only the parasympathetic fibers, they relay into the ganglion. Sympathetic and sensory fibers, they actually pass through the ganglion uninterrupted. There is no any relay into the ganglia. So we will first discuss about the parasympathetic root. So mainly parasympathetic root, here you are able to see it arises from the Edinger-Westphal nucleus. So accessory nucleus, Edinger-Westphal nucleus, the fibers they arise and they pass successively through the oculomotor nerve. Then when the oculomotor nerve divides into superior and inferior ramus, it passes via the inferior ramus. Then via the branch to the inferior oblique, and finally what happens? It will reach the ganglion. Then after relay in the ciliary ganglion, it will actually travel via the short ciliary nerves. Okay, many short ciliary nerves are there which passes above and below the optic nerve. They pierce the sclera of the eyeball, and finally they supply the sphincter pupillae and the ciliaris muscle of the eyeball. Okay, so it is mainly the nucleus is the preganglionic fibers from the Edinger-Westphal nucleus. Fibers pass through the oculomotor nerve and then through the inferior division of the oculomotor nerve, and then through the branch to the inferior oblique, it will actually relay in the ciliary ganglion. Then postganglionic fibers start from the ganglion. They pass through the short ciliary nerves. Mainly they pass through the short ciliary nerves and pierce the sclera of the eyeball and then supply the ciliaris muscle and the sphincter pupillae. Coming to the sympathetic root. So sympathetic root, mostly all the structures in the head of neck, the fibers for the sympathetic root, they are the preganglionic fibers. They arise from the lateral horn cells of the thoracic segments of the spinal cord. The first 4 to 5 thoracic segments of the spinal cord. What happens is the fibers, they arise, preganglionic fibers, through white rami communicants, and then they pass via the inferior, middle, and finally relay into the superior cervical ganglion. Okay, they bypass the inferior and middle preganglionic fibers and relay into the superior cervical ganglion. Fibers from the superior cervical ganglion, postganglionic fibers, they travel via the arteries, branches of external and internal carotid arteries to reach the target areas. Now, in case of the dilator pupillae, will definitely the plexus will surround the internal carotid artery. The internal carotid artery through the carotid canal and then enters the skull and then comes out through the posterior part wall of the lacerum, and then it will travel via the cavernous sinus. So there the sympathetic fibers, what happens, has actually communications with the oculomotor nerve also. Then the fibers will continue from there, branch of the internal carotid arteries, the ophthalmic artery. Through this, it will just reach the ciliary ganglion. Then the fibers does not relay the ciliary ganglion, they pass via the short ciliary nerves. Some of the fibers are also thought to pass via the long ciliary nerves also. Then finally they supply the dilator pupillae muscle, which has the opposite action of the sphincter pupillae. Both are for accommodation. Okay. So finally coming to the sensory branches from the nasociliary nerve, they are nothing but the short ciliary nerves only. They actually pass through the ganglion uninterrupted and then they actually pierce the sclera and they are sensory to the eyeball. Mainly temperature, thermal sensations and touch sensations from the eyeball and also from the cornea, iris and the ciliary body. They convey sensations, short ciliary nerves. So if the parasympathetic fibers are affected, then naturally what happens is the pupil does not react to light. It is called as fixed or adytonic pupil. If you actually, what happens is if you project a beam of light into the eye, just throw a beam of light via torch light, the pupil won't react, and that is called as the fixed or adytonic pupil. So thank you very much for your patient listening. We will meet again with one more topic.